Welcome to the Cystic Fibrosis Foundation's virtual patient education day, Navigating the Hills and Valley of CF Lung Disease, a webcast supported through an unrestricted educational grant from Genentech. I'm Leslie Hazel, Director of Patient Resources at the Cystic Fibrosis Foundation. This webcast will explore ways that people with CF, families and friends, can maintain healthy lungs, the importance of regular CF clinic visits, how you can partner with your CF care center to identify a pulmonary exacerbation early, and learn how it is treated. If you have specific questions about maintaining healthy lungs, please type it into the lower left-hand corner of your webcast window. However, questions not related to this topic or that ask for medical advice will not be asked or answered. To learn about nutrition in CF, quality improvements in CF care, building life skills to manage CF, the latest in research, patient advocacies, issues and answers related to insurance and government programs, and how to avoid germs, please watch an archived webcast on the CF Foundation's website. As with the other webcasts, this one will also be watching. Our presenters tonight are from Akron Children's Hospital in Akron, Ohio. Betsy Bryson is the pediatric nurse practitioner at the CF Care Center. Dr. Nathan Kranak is the director of the CF Foundation Accredited Care Center at Akron Children's Hospital. And Chris Singh is the coordinator as well as the adult nurse practitioner for the CF Care Center. Here's somebody who wrote in during registration. They said in October their nephew will be born with cystic fibrosis. They want to know what lung problems might their nephew have and what can the parents expect?
Well, Leslie, that's one of the most common questions I get asked as a pediatric pulmonologist taking care of kids who have cystic fibrosis. Most importantly, or most frequently when we get asked that is the first time we meet a new patient who was just recently diagnosed with CF. And what I tell them basically is that there are three main problems with the lung disease in CF. And those three problems contribute to a fourth problem. The first problem is what we call airflow obstruction. It's when there is mucus in the airways. And the mucus in CF is different. It's very thick, it's very sticky, and it literally can block airflow. Whenever there's fluid that sits around in our bodies and it doesn't move, it can get infected. So the second problem that we see in CF is airway infection. And they're infected with different types of bacteria such as Staph aureus or Pseudomonas aeruginosa. And that infection tends to persist. It's very difficult to treat. It's very difficult to make that infection go away. The third problem that we see is inflammation. And inflammation is a normal response to infection. That's inflammatory cells coming into the airways to try to fight off that infection. And what ends up happening is that the three things, obstruction, infection, inflammation, all work together to cause progressive lung damage, which is what makes people feel sick as they get a little bit older. And as you can see on this slide, on the left side is a normal airway. So you can see the airway is nice and wide open. Airflow is very easy, can very easily flow through that nice wide open space. The airway walls themselves are actually relatively thin. But on the right side of the slide, you see that there is, in the CF airway, there is a lot of mucus. That mucus obstructs the airflow. We know there's infection in that mucus, and that infection brings in the inflammation, which is what over time damages the lung.
Well, let me ask you a question, and this one actually came in live. It seems to fit in very well here. They want to know, is it true that repeated infections cause scarring in the CF lungs, making them less flexible and harder to breathe in and out?
Well, it is true that recurrent infections can damage the lung over time. And one of the things that we're going to talk about a little bit later on is how we treat those infections. And one of the things that is very important is for you to tell your CF care providers when you start to feel sick so that they can start that treatment as soon as possible.
So what are the first symptoms of CF lung disease, and how will somebody know that they're having problems with their lungs?
Well, the symptoms that we look for are cough. We look for increased mucus production, or sputum as we call it, which older individuals with CF can often produce. So it's the mucus you can cough up and out. Obviously, a young baby might not be able to cough up mucus, and so we'll ask about chest congestion. How do they sound? Is there any rattling in their chest? We'll ask about wheezing. We'll ask about shortness of breath. We'll ask about subtle things like if your child's out running around playing soccer, are they starting to slow down? Or can they not keep up with their peers? Well, also, things that we look for are decreased lung function. That's something that Betsy talked about a little bit ago that we will follow with just about every visit in children who are old enough to do those tests. We'll also look for physical exam findings, decreased airflow into the lungs, crackles, wheezes. And we'll also just look at some other things like, are you just feeling bad? Do you feel a little bit run down? All of those things can be signs and symptoms that you're getting sick.
Well, here's a person who says that their sputum culture always shows bacteria in their lungs, and their CF center calls them chronically infected with Pseudomonas. So what's the difference between being chronically infected and having a pulmonary exacerbation?
Well, that is actually a great question because it's something that we often are asked. And I think the key point with a chronic infection is to think that that infection is always there. That's one of the things we just don't quite understand about cystic fibrosis is why we can't get rid of that infection. But it's there all the time. Even though you may get antibiotics, that infection doesn't completely go away. And a lot of our maintenance therapies are really designed so that we can either get the mucus that's infected up and out of your lungs or decrease the amount of bacteria that are in your lungs if you have CF. And that's really why doing treatments with cystic fibrosis is very important and staying on your plan of care so that you can get that mucus out, keep that bacterial load as low as possible. But sometimes no matter what you do or what your child may do, that bacterial infection just sort of flares up. And it's that flaring up that we call a pulmonary exacerbation.
You just mentioned bacteria load. What do you mean by that?
That's sort of like the amount of bacteria that are in your lungs. And because that infection is always there, sometimes it can be just a relatively small amount of infection. And you're usually, when that happens, you feel pretty good. But sometimes over time it increases. Maybe you get a little bit of a virus that might get you under the weather a little bit. And then that bit that allows that bacteria to grow up, have more bacteria in your lungs, you may start to cough, produce more mucus. So you start to feel sick.
So how does the providers at the CF Center know when a person with CF has a pulmonary exacerbation?
Well, that's actually a pretty tough question to answer, and it's something that we've actually studied at the CF Center in Akron. We really looked at the way that we practice in a very standardized fashion. We actually developed some cases, some little stories about a patient coming into our office. And basically we asked all of the 8 care providers at our center at the time, how would you treat this person? Would you put them on antibiotics? Would you just have them come back in a month or two? Would you bring them into the hospital? And what we found out is that when we answered those questions in a very standardized fashion, we were doing things a little bit differently. And obviously that's pretty frustrating. That was frustrating to us because we would certainly like to all do things in a standardized fashion, but it was probably even more frustrating to our patients and our families. And so that really got us on the track to develop a standardized way to identify exacerbations. And that's something that we've been using.
Okay, so how did you get to a standard definition for pulmonary exacerbation? What did you look at?
Well, the first thing we looked at is actually the medical literature. We looked at what other CF centers had done to examine exacerbations. And so we read a number of papers. We actually sat down as a group and came to a consensus about what things we thought were important. And that was all part of a much larger project, which we got involved in through a quality improvement initiative that was sponsored by the Cystic Fibrosis Foundation. And quality improvement is a sort of standardized ways to tackle a problem and improve the type of care that you can give. And through that process, the Cystic Fibrosis Foundation encouraged us to look at our own center, to look at what our lung function was. In our case, we found that our lung function in our pediatric patients was below average. We weren't very happy about that. We were a little bit frustrated about that. And so what we did, when we realized we were doing things a little bit differently with respect to pulmonary exacerbations, is we developed a standardized score. And that standardized score, if it was above a certain threshold value, a certain number, we called that a pulmonary exacerbation, and we recommended treatment for that patient. And what we did over the ensuing 2 years of developing that score is we tracked the use of the score and we tracked our pulmonary function in our pediatric patients.
So what's the score look like?
Well, the score actually has 3 different parts. It has what we call a systemic symptom part. It has a pulmonary symptom part, and it has an objective measurement part, so something that we can sort of measure. And basically what we did is and I'm showing the sheet, the pulmonary exacerbation scoring sheet, or PES as we called it, that was put on every chart of every patient who came to our CF center for over 2 years. And when you look at the systemic symptoms, which I'm showing right now, you see that we looked at fever, we looked at malaise, or just not feeling good, or if someone was more tired than usual. We asked if anyone had missed any school or work because they weren't feeling well. We asked about poor appetite. And we also looked at weight. If someone had lost some weight, that was something that we thought was very important. We obviously had a pulmonary part, or a lung part, where we asked about cough. We asked about mucus production. We asked about if people were short of breath, or if they were running around, did they get more tired than usual? And we also looked at different lung findings. So did someone have decreased airflow on their exam? Did someone have crackles on their exam? So that was important for our pulmonary findings. And then we had some objective measurements. Something that we tend to follow in cystic fibrosis is something called the FEV1, or the forced expiratory volume in 1 second. Mm-hmm. It's a pulmonary function test that we will get on just about every patient who's over 6 who can do that type of testing. And we looked at that. We looked at chest X-ray findings, if someone should happen to have a chest X-ray available. We didn't go out and get chest X-rays on everybody who came in, but if we thought it was necessary to get one, we put that into our score. We looked at if someone had been coughing up any blood, which is something that can happen if someone is getting sick. And we also looked at if their oxygen level was dropping.
So what were your results, and did you find that it was helpful?
Well, we found it was very helpful, and I'm going to show a slide right now which shows those results. So between 2002 and 2004, we were not using our pulmonary exacerbation score. We developed it through the summer of 2004, and in the fall of 2004, we began using it. And we've used it ever since. We used it in a very controlled fashion over 2 years, and we've continued to use it. And what you can see on this slide is that the red line, which shows our youngest patients, our kids 6 to 12 years old, we saw a pretty significant increase between 2004 and 2005, and a sustained increase in 2006. We saw similar findings in our older children, so kids age 13 to 18. And I'm going to ask Chris a question. What did you see on the adult side?
Well, we were really closely involved in the exacerbation project along with the pediatric team. But what we found at the beginning of the project was that our adult pulmonary function values were actually higher than national average. But we continued on with the project. We participated along with the pediatric team, and we've maintained that same above average status.
So this sounds like a fabulous project, but do you still use this? What are you doing now?
Well, we do use it, and we've now actually standardized this into our practice. We actually changed the clinic record that we have, the little sheet that we fill out whenever we see our patients, and it has this score built right into it. It's there for ease of reference, and we encourage all of our providers and even residents and medical students who may be rotating with us, and we teach them about the score, teach them how to fill it out. And we've been using it. We have continued to see improvement. We have some lung function information from 2007, and it continues to increase. And what was sort of something that we didn't really expect, but was really a really neat thing to find, is that this is a wonderful education tool for our patients and families. Now we have people calling us after a week if their child's cough continues, because that's on the score. They're calling us up and they're telling us, my child's coughing more, they have more mucus, and they're calling us maybe 2 or 3 days before it's a week, so that they can know, well, what should I do if it gets to be a week? Should we start antibiotics? And so it's really been a great tool for us to educate our patients and families about what we're looking for to determine if someone's sick.
Great tool for identifying a pulmonary exacerbation, but how do you treat one?
Well, that's a great question, Leslie. And just as defining a pulmonary exacerbation is not so straightforward, same with treating exacerbations. So there's many factors that we look at as providers in treating exacerbations. The first being the severity of the signs and symptoms. A patient who comes in with more mild symptoms will be treated differently than a patient who has much more pronounced symptoms. We also look at the severity of the CF. Patients who have more severe disease are going to have a much more aggressive approach in the beginning than patients who have mild mild disease or normal lung function. We also look at the recent sputum culture to make sure that we're using appropriate antibiotics, but we also may go back and look at past throat or sputum cultures to make sure we're covering other bacteria that may have been there in the past. We also want to look at past responses to antibiotics. One would be just certain regimens may work well for certain patients, so we may try that approach first. Other times, the patient may have had some side effects with the medicines, they may have had allergies, so we always consider different responses in the past to antibiotics. Another big issue is the financial issue. If a patient doesn't have insurance, that may weigh on your decision on how you're going to treat. Also, the patient's ability to follow the plan of care, how they've done in the past with home treatment will be a factor. And then just overall, their support systems, all their work and their school situations will come into play too.
Okay, so those are the things you consider. What do you do, or what do you prescribe?
Well, we really try to cover 4 components, and the first one being we want to treat the infection. So we use antibiotics to treat the infection, and what antibiotics are, they're drugs that inhibit the growth of the bacteria in the CF lung. And you can actually take those 3 different ways, and the first one being oral antibiotics, and you could take that either in a pill or liquid form. The other form would be inhaled antibiotics, and that's actually a liquefied antibiotic that you nebulize into the CF lung directly. And the other one being intravenous or IV antibiotics, which is infused right into the vein through an IV line. The next piece that you never want to miss is clearing the mucus. And during exacerbations, patients usually report that their secretions are much thicker. They usually change color. A lot of times they're stickier. So typically we'll take the approach of increasing airway clearance. Now at times we may actually have to try a different approach and use a different form of airway clearance. We also want to address nutrition. Usually during exacerbations, when a patient first comes into clinic, we may see that they've lost weight. That can be from various reasons. It could be due to decreased appetite, just because they're not feeling well. It could be just increased calorie needs because they're working harder to breathe. All the inflammation and infection can also increase calorie needs. So we want to make sure that we're meeting the needs of the patients as far as nutrition goes, and that we're monitoring their weight. And again, last, monitoring the response and making sure that the therapy is adequate, that the patient's responding to it well.
So how does a provider choose what antibiotic or what type of antibiotic for an exacerbation? Why can't somebody always take a pill? Why do they have to get an IV?
Well, when you look at choosing an antibiotic, the first thing that you think about is the bacteria in the CF lung. And some bacteria are very sensitive to oral antibiotics, and you may have a lot of choices. But other times you may not. You may have a bacteria that's more resistant, and you may have to use IV antibiotics. Another is age. Antibiotics that are used in an older child or in an adult may not be used in a baby. You also consider previous antibiotics that have been taken in the past, how they've responded, allergies, side effects that they've had, and then insurance coverage. Sometimes, as long as the insurance coverage may tell you which antibiotic will be covered, so as long as that's appropriate, we may use that. So talking about oral antibiotics, the first thing you want to, what we typically use them for is for more mild exacerbations. Usually they're taken over 2-week course, sometimes a little longer. Again, the big point to take home is follow-up at the end of the course of antibiotics to make sure that you're feeling better. The next type is inhaled antibiotics, and those are very convenient and well tolerated in most patients. Typically we use them in combination with oral or IV antibiotics. And what we recommend patients do is to do all their other aerosolized medicines and their airway clearance, and then to inhale the aerosolized antibiotic at the end. And the IV antibiotics are infused directly into an IV line, and they're really considered the most effective way to treat severe exacerbations. More often we use 2 antibiotics when we do IV antibiotics, and typically it's over a 2 to 3 week course, and that depends on the patient's response to the treatment.
So you mentioned bacteria sensitivity. What's that mean, and what are common antibiotics that are prescribed?
Well, bacterial sensitivity literally means what antibiotics the bacteria is sensitive to. So when we get a sputum culture, we can literally grow those bacteria up on a little plate, and we can determine in the lab which antibiotics best kill that bacteria. And so as you can see on this slide, which is an antibiogram is what we call them, and you see a number of antibiotics listed on the left side of the slide, and then you see a number of S's, and that S stands for sensitive. Oftentimes we'll see R's, which stands for resistant. And what that really means is that that bacteria is not killed very well by that antibiotic. And so we can use this sensitivity pattern to help us determine which antibiotics are going to kill those bacteria the best. The other thing is, as far as common antibiotics, oral antibiotics usually come in different sorts of flavors, and one of those flavors is Cipro or ciprofloxacin, which is something which is very commonly prescribed, and that's usually prescribed for chronic Pseudomonas or a Pseudomonas aeruginosa exacerbation. Other ones are Bacterial, doxycycline, Keflex or cephalexin. Those are usually used to treat staph. Azithromycin is a relatively new therapy that we've been using in CF, which also has some activity against Pseudomonas, we think. Inhaled antibiotics, the most common one there is going to be Toby or inhaled tobramycin, and that's active against Pseudomonas. And then intravenous antibiotics include tobramycin, the cephalosporin, something like ceftazidime, meropenem, or aztreonam.
So how long will someone have to take antibiotics?
Well, typically, like I said before, we usually go over 2 to 3 weeks for antibiotic course. Sometimes we'll go a little longer, and the goal is to get the patient back to baseline or to their best before the exacerbation. And we'll be looking at not only their symptoms, but their PFT, chest x-ray, how they sound as far as their lung sounds, their vital signs. But what's important to remember is that the patient take the antibiotics as directed, so that way, and to continue with it even if they're feeling better, because we want to avoid bacteria resistance.
So somebody who's been on antibiotics for a couple weeks, they go in and see their doctor just like they're supposed to, and the doctor goes, we're going to have you be on antibiotics for another week. Why? How does the doctor or the provider come to that decision?
Sure. Well, we look at different variables. Again, how is the patient feeling on antibiotics? We may have someone come in and their PFT is better, but they're still not feeling real good. So we may extend for that reason, or vice versa. They're feeling better, but their PFT isn't better. We also want to look at side effects. So if a patient has side effects from medicine, we may have to change, and that may extend therapy also. Again, looking at the laboratory data, the chest x-ray, the PFT will help us decide whether or not, if that's not improving, we would extend at that point, or we would stop. And then again, how do they sound? How do they look overall? Are they breathing easier? Those are things that would guide you into whether you should stop or not.
So somebody's got a severe pulmonary exacerbation, they're on IV antibiotics, and you tell them they have to go to the hospital. Why can't they do those at home? Why do they have to go to the hospital?
Well, there's advantages and disadvantages with home therapy versus hospitalization. The biggest advantage with home therapy that I hear my patients saying all the time is the convenience, that they're able to continue their life as they did before with doing their IV antibiotics. Another could be the cost, and that could be very significant for some patients. It's much less expensive than a hospitalization. Some of the disadvantages are, though, it's very time consuming, and a lot of times our patients may not realize you're not only talking about doing the antibiotics itself, but you're talking about getting enough rest, airway clearance, getting adequate nutrition. You're also getting followed up a little less frequently, so you're not being seen daily, you're being seen more or less weekly. And we also want to maintain your IV line when you're on therapy, and there can be some inconvenience for the patient if they would lose their IV line while they're on therapy. And also just being available by telephone, that's very important. If you're a person who's not available easily by telephone, that's an ultimate for safety with home IV. As far as monitoring, we typically see them daily in the hospital, so we will see an improvement. Sometimes patients will say they feel an improvement faster because we can maybe monitor for other conditions that may come up while they're in the hospital. And typically they're just being taken care of by caregivers 24 hours around the clock, and they have immediate access in that 24-hour support. As far as disadvantages, it is very regiment, the hospital, so the patient has to adjust to the hospital schedule, which can be difficult for some of our patients. It's also costly, and again, depending on your financial situation. It can be isolating for patients with either CF infection control policies, and also because of missing out on their activities and their normal caregivers, that they have different caregivers while they're in the hospital. There's also risks for new infection, which can be very concerning for CF patients.
So somebody's got a pulmonary exacerbation, they're on antibiotics. What should they do if they're not feeling better?
Well, it's real important for them to call us and let us know as soon as possible if they're not feeling better. And I also feel it's really important for patients from the very beginning to ask questions and to make sure that they're a part of the plan. And if they don't feel that they can handle a certain regimen, that we know about that. I'd rather know about that in the beginning than wait till they haven't responded well in the end. And to communicate changes to us. If they're not feeling good, if they're having a side effect from a certain antibiotic, that they not stop it and not tell us, that we need to know about those things. Also, following up is really important, and you may have to come in sooner than later if you're not feeling well. So calling and making an appointment would be a great start. And just knowing that you are the center of the CF team, we are here for you, and that being an active participant in your plan of care is very important.
Somebody who's 25 submitted a question who has CF, and their pulmonary function, or FEV1, is in the 70s, and they want to know if the progression of CF lung disease is gradual, or are large portions of lung function lost when you've got a really bad pulmonary exacerbation or a series of really bad exacerbations?
Well, Leslie, I think the answer to that question is really both of those things can occur. And this slide shows a pulmonary function trend, or a pulmonary function graph. This is something that all of your care centers can print off of the Port CF database, which comes from the Cystic Fibrosis Foundation's registry. And we really like to use these because, as you can see, that pulmonary function can vary quite a bit. And this is actually one of the patients at our center. This is a younger person than someone who's 25, and their lung function is quite good. It starts off at about 110% predicted, which is great for their age. But as you can see, as we sort of go along through the next few quarters, that lung function begins to drop off. And at this point, the child's starting to get sick. This was a relatively mild exacerbation, so you can see the lung function begins to drop a little bit. We treat that with antibiotics. It comes up right back to their baseline, just above 110% again. But then there's this enormous drop. This was a severe exacerbation. Child came into the office, was very, very sick. We had to admit him to the hospital, and he was on IV antibiotics for quite a while. But we kept going, and the family was interested in continuing, and he didn't quite feel better, so we kept on going with antibiotics, and you can see his lung function finally came all the way back up. But you can see right after that it starts to come down again. And so we were lucky enough in this patient, and we were persistent enough, and they were persistent enough with their therapies to get that lung function back up. Sometimes we can't, and that lung function is lost. But other times you don't have to have a very severe exacerbation to lose lung function. You can just sort of lose it slowly as well. And we tend to see that in people who are maybe not so persistent with doing their daily therapies.
So what's the best way to prevent a pulmonary exacerbation?
Well, what you really want to do is follow your plan of care and be an active part in talking with your CF center about what you think is the best form of plan of care for you. And also, sometimes you will get sick, and not all exacerbations can be prevented, but just remember that your CF center is just a phone call away.
So here's a question that came in live, and this is, I don't even know if this is possible, but they say that their child has had a pulmonary exacerbation without a bacterial infection. Is that possible?
Well, I think I'll take that question because everybody's looking at me. Well, I think it is possible, because we have to remember there are three things going on in the CF lung. There is the infection part, which is a huge part, but there's also the airflow obstruction due to the thick, sticky mucus, and there's also the inflammation. And so maybe for some reason the amount of bacteria there are very small so that you can't culture it, or it could just be that for whatever reason there's more mucus there, there's more inflammation there, and infection isn't playing a huge role. But I would suspect there probably is some infection there, and sometimes it's just difficult to culture.
Well, another question that came in during registration is there a recommended order that people with CF should take their nebulizers or inhaled medications?
It is often confusing when you have so many different aerosolized drugs of which ones to use first. And although there has been only a few studies looking at that, when you think about all the different ones, it makes sense of what order your CF center would recommend that you do them in. First, what you want to think about is how you're going to open up the airways. So you'll use your bronchodilators such as your albuterol or your Xopenex. Then the next thing you want to do is get rid of the thick, sticky mucus by thinning it using hypertonic saline or pulmozyme. Next, what you want to do is get that mucus out of the lungs. And so you will use your airway clearance, your vest, your acapella, your flutter, or your postural drainage. And finally, the last thing you want to do is get in those aerosolized antibiotics last deep down into the lungs. And those would be something such as tobramycin or Toby.
Somebody asked live, what can their child eat to fortify their lungs from infection? And this is a bunch of questions we've gotten, and that is, what's the impact of nutrition on CF lung health?
That's actually one of my favorite questions, because we get that a lot. Because everyone wants to know, well, why is nutrition so important? And when I tell people something simple, the nutrition bone is tied to the lung bone. And we know that nutrition is very, very important for getting calories. And calories are really the building blocks of the body. And so our immune system works better if we have good calories. We can fight off infections better if we have good calories. We can be stronger. We can grow taller. Nutrition is so important because one of the things that we've learned relatively recently is that if children with CF grow like normal children, like kids who don't have CF, their lung function is better than kids who don't grow well. So the lung bone is tied to the nutrition bone.
So somebody asked, you talked about pulmonary function and doing a FEV1 test, and you mentioned that on kids who could do it 6 years and older, can they do pulmonary function tests on infants, and if so, how?
They can do pulmonary function tests on infants. Now, not every CF care center does them. And there was, I believe, a few years ago, a study that was started, sponsored by the Cystic Fibrosis Foundation, looking at infant pulmonary function tests, which is a very specialized technique. It's a very specialized device, an infant pulmonary function machine. And there were a number of centers across the country who were doing infant pulmonary function tests. I don't believe the results of that study have been published yet. So they can be done, and ask your CF care center if they know of other care centers who may be doing them, if you're interested.
Here's something that came in. They're asking if their child, if playing a musical instrument like a clarinet or a wind instrument would help their child's lung pulmonary function and their lung health.
Do you want that one, Betsy?
We actually, that's an interesting question, because we actually have several CF children and teenagers at our center that do participate in the band. And what we do tell them is using an instrument, especially like a wind instrument, is similar to some of the things like an acapella or flutter, and it does help open up the airways, cause some vibration, may have them cough a little bit, but it should not be a replacement for airway clearance that they do. The other thing, as I talk about a lot with infection controls, it's important to make sure that those instruments are clean and not harboring bacteria that could be harmful to someone with CF.
And so how does somebody find out how to clean their wind instrument?
I think the most important thing is that you could check with the people where you get your instrument and see if any of the ways that we talked about cleaning respiratory equipment would work with the instrument that you have.
A little bit different tact. Somebody was asking, are IV antibiotics always better? Are they always stronger? Are they always faster acting?
I could take that. I think it's very variable. I think sometimes you can see that an oral antibiotic, depending on the bacteria the CF patient has, can actually work very well. Sometimes we've seen patients do well on orals and not on IVs. So it just depends on the patient. But I think what's most important is getting all those pieces in, not just the antibiotics, but the airway clearance and the nutrition.
Kind of going back to antibiotics and bacteria, somebody has asked, and you talked about sensitivity and resistance to organisms. They want to know, is there an increase in bacteria-resistant organisms in people with CF if they've got a chronic infection? How fast does resistance develop? And is there something that people with CF can do to either make resistance to an antibiotic happen faster, or can they keep it slowed down?
Well, the answer to that question is that resistance will occur in almost any bacteria over time. And one of the things that you can do to prevent that from occurring is to make sure that you take all of your antibiotics when they're prescribed. We think the best way for a bacteria to become resistant to an antibiotic is to see a little bit of that antibiotic for, say, maybe 2 or 3 days, and then you stop. And when you stop that antibiotic, that bacteria's seen it, it's starting to figure out a way to become resistant to it. And then once it happens in one bacteria, they just divide so quickly, then you have many bacteria that are resistant to it. We also know that some bacteria can transmit that resistance to other bacteria. So they can almost talk to each other.
Airway clearance, a couple of questions that come in. Which method is best? Is it the vest? Is it an acapella or a flutter device? Is it manual chest physiotherapy? What's the best way to do airway clearance to get that mucus out of the lungs?
Well, I think the best way to do airway clearance is to do what works for you. One of my mentors in training told me that no therapy works if it isn't used. And so what I encourage everyone out there to do is to, if your child likes to use the vest, great, have them use the vest. If they hate the vest and they want to use another device, say the flutter or the acapella, make sure they're doing it appropriately. So check with your care center, check with your respiratory therapist or physical therapist on your team. Make sure they know how to do it right. And have them continue to use it on a regular basis. We do know that airway clearance devices like the vest and like the flutter have been studied against what we consider to be the gold standard, which is chest percussion and drainage or postural drainage. And we know that those therapies are no better, but the advantage to them certainly is that you don't need an extra person to do it for you. You can do it on your own. And you can do other things while you're on it. I'm always impressed with how our younger kids can sit there on the computer and type while they're on their vest. I can't type and I don't have to use a vest.
Leslie, often we find that people use multiple ways of doing their airway clearance. And so sometimes the kids may find like a flutter or an acapella would be easier to do before school, and then they'll do their vest afterwards. So sometimes if something's not working, to be able to have different ones to intermix also is helpful.
Well, Chris, is there a difference with the adult population?
Sure. I think as a patient's lung disease progresses, they may have to look at other options. Sometimes using the flutter or the acapella, it can be harder to move air. So sometimes a more dependent form of airway clearance like the vest or chest percussion would be better for those patients.
Maintenance, what are the recommended standard, daily, chronic maintenance medications that help to maintain lung health?
Well, that's really a great question, as many of these questions are, and we've said it a lot of times. But there are some guidelines that we have seen that are in the process of being published that just talks about those types of therapies, and they're the common therapies that many of you out there have heard about. Medications like DNase or Pulmozyme, medications like inhaled Toby or inhaled tobramycin, azithromycin for chronic Pseudomonas, hypertonic saline. So the very common medications that people use. Bronchodilators are recommended to help open the airways up before airway clearance. So it's a lot of the common things, and that's going to be coming out soon. And so make sure you ask your care center about what they recommend, but it really is an individual thing. If you have a question about a medication that you or your child is not taking, ask your care center. Ask why you're not taking it.
Along those lines, how long should one continue uninterrupted use of these medications? You mentioned Pulmozyme, hypertonic saline, azithromycin, which isn't inhaled, or Toby. Are there any long-term effects with these maintenance chronic therapies?
Well, most of these medications, when they've been studied, show that people's lung function improves when they're on it, or the number of exacerbations that they get while they're on that therapy seem to decrease. What we have also seen is when someone comes off that medicine, their lung function seems to go back to what its baseline was, and we presume that exacerbations go back to their previous rate. So what we tell most of our patients, if we start a chronic therapy and they respond to it and they don't have any side effects from it, to stay on that medication and to stay on it indefinitely unless there becomes some problem where they can't tolerate it for one reason or another.
On these basic therapies, somebody wants to know about the salt therapy or hypertonic. They have a 24-year-old daughter who seems to do better in areas along the coast. Is there any truth to that, or is that just in the daughter's head?
I doubt it's in the daughter's head. And actually, serendipitously, that's how hypertonic saline was discovered. There were a number of researchers and CF providers in Australia that noticed that many of their patients who were surfers, so they spent a lot of time in the ocean, they were inhaling salt water all the time, actually did better than those who didn't live near the coasts. And so they developed hypertonic saline, and they studied hypertonic saline, which shows that is an effective therapy.
A little bit different tact, and this has come in 2 questions live. They want to know how or when do you know the severity of CF lung disease for like a newborn? And is there any specific gene mutation or correlation between your mutation and severity of your lung disease?
Do I keep talking?
Yeah. Okay, I'll give the next one to somebody else. But go ahead.
The Nate Show.
The Nate Show. Well, we do know that there are some mutations, CF gene mutations, that are associated with more severe disease. But there are also things which are called gene modifiers. And so that can potentially explain why when you know 2 people have the exact same CF genes, one person does relatively well, the other one may have more significant disease. So you can't go just based on the type of mutation that you or your child has. And on the flip side of that, there are some mutations which tend to be associated with relatively mild disease. And that does seem to hold up a little bit better. So you can't predict a little bit, but what I tell everyone is it doesn't matter what genes you have. The important thing is to stay on your therapies, and that's going to give you the best chance of staying as healthy as long as possible.
Well, kind of along the same lines, somebody asked, what are the long-term effects of somebody who has mild lung disease, but they don't do any of their prescribed maintenance therapies? What's the long-term impact on that?
You guys fight over this one.
Go ahead, I'll pipe in.
Well, Leslie, we often see this, especially with some of our teenagers who are in that independent stage and are feeling so good and their lung functions are fine and they're not really having a cough. They think, why do I need to do these medications? Why do I need to do this all the time? And we explain to them that a lot of it is our goal is to keep your lungs the best health as possible and to continue to do those treatments even though you may not see a change on a day-to-day basis. And one example that I use, especially with the younger kids, is kind of like brushing your teeth. If you miss it 1 or 2 times, you may not notice a difference, but long-term wise, you're going to get cavities and more problems afterwards if you don't continue to do the treatments that you need to do as you go along.
Were you going to add something to that, Chris?
I would just reiterate what Betsy said, and it's not looking at how you feel today compared to how you feel tomorrow. It's really looking at that long-term, how you're going to feel 5 years from now.
Somebody just sent in a question. They want to know, number one, what sports could their child participate in, and where should they draw the line and say, no, you're doing too much, you have to rest?
You know, I think that's a question a lot of our families ask, and it's especially when people are newly diagnosed. They want to know, does my child going to look different than anybody else? Are they able to participate in the sports? And we say that if you took all of our CF patients and put them in a school, it would be difficult to see who has cystic fibrosis and who doesn't many times, because they do participate in soccer and swimming. So we do not say that there's one sport that's better for them or not good for them, but they need to have their treatments in order to be able to do that. Some of them may have a component of asthma that they need to use some of their bronchodilators along with their sporting events also.
So exercise is important as part of the regular treatments or care that someone with CF needs to do for their lungs.
Sure, we encourage that they do exercise on a daily basis, and sports is a great way to do that exercise. But we also encourage people, if they're not participating in sports, to do exercise by riding their bikes or walking, and maybe you can do it as a family also.
So what do you see the role of parents and how do they work in the transition of a child who's now 18, 19, they've been in the pediatric CF care center their whole life. Now they've got to go to an adult care center and an adult hospital. How do they help with the transition, and how can parents maintain an active role in their child's health care, and the child's now an adult?
You know, that's often a difficult thing for parents to do. They've spent the last 18 years working with their child to try to make them the healthiest possible, and then all of a sudden they go off to college and they feel like they don't have much control in what are they doing at that time. So we start early on, early in the teen years, to encourage the child to become more independent, to educate them about their cystic fibrosis and help them learn why they need to take these medications. At the Akron CF Center, we have an adolescent clinic that is after school so that they're not missing their school, and we encourage that the patients are in a room by themselves, and I coach the parents that what you need to do is have your child talk about on the way up for that visit what kind of things they'd want to talk with the care provider. And then we see them in the room by themselves and then bring the parent in afterwards so we can kind of move through that process in that way. And Chris may have something to add as they come into the adult clinic, how the difference is from pediatrics.
Well, again, it's I guess it's learning, it's fostering independence in your child, and it starts again at the adolescent age. Teaching them how to handle maybe some insurance issues, walking them through those pieces, walking through how to refill their medicines, and calling the CF center when they have a problem, walking them through those pieces. You may take one at a time over a couple year period of time. And once they come to the CF center, typically we have the adult CF center, we have a visit where we have the parent in the room for the first time, but we tell the parent that from now on we're really going to want to maintain some privacy for the patient. They can be a part of those discussions if they want to, but there may be times where we want to have a private conversation with them.
We're getting down to the end, but I want to ask this question that came in live, and they want to know what's the difference between a non-mucoid strain of Pseudomonas and a mucoid strain of Pseudomonas bacteria growing in the lungs.
Do you want me to take this one?
Sure.
Okay. A difference between a non-mucoid and a mucoid strain of Pseudomonas really comes from how it looks on the plate. And so when we plate these bacteria out and they begin to grow, the mucoid strains surround themselves with literally a layer of slime. And that it helps protect the bacteria from antibiotics and from the immune system. So mucoid Pseudomonas is much more difficult to treat, and as far as we know, may be almost impossible to eradicate. So what we try to do is prevent, if we can, the transition from non-mucoid to mucoid Pseudomonas. And to be honest with you, there are not a whole lot of ways to do that right now, but that is something which is under very intense study in a number of labs all over the world.
Here's something this woman with CF she describes it as a mild to severe case. Is it still a risk for her when she decides to get pregnant, and would this be considered a high-risk pregnancy?
Well, what I always tell patients, if they're actively pursuing a pregnancy, that they need to talk to their CF center so that we can make sure that they're at their optimal health that they decide to do that, or we could advise them if they are active, if they should be pursuing pregnancy or not. But it is a higher risk because any pregnant woman will have increased cardiopulmonary or increased their lung needs while they're pregnant. So if you have an underlying pulmonary condition when you're pregnant, it'll just be more so. So there's closer monitoring while they're pregnant. We typically like to see our patients at least monthly, and we also want them to be seen by a high-risk OB. So there is a risk, but we hope to minimize it by close contact with the patient.
Couple of lung transplant questions that came in. When do you know that it's time for lung transplant? How well can someone with CF recover from a transplant? And can the transplanted lungs get the old CF bacteria? I know that's a lot.
Well, maybe we each can take one of those questions.
Help yourself.
I'll take the first question about how do you know when it's time for a lung transplant? And what we really look at is what the FEV1, the measure your pulmonary function, when it's down to about 30% or somewhere in that area, you know that the length of survival is decreasing at that point in time. But you also look at other things are they able to maintain their normal lifestyle? Are they needing oxygen? Are they in the hospital more frequently? And often what we tell our families is, this is a time when it may be coming time for a referral for a lung transplant, but it's only the lung transplant center themselves that really can make the decision. So we help families look at the options for lung transplant referral centers and get them to the lung transplant referral center to help them make that decision.
Okay, recovery and organisms, bacteria in the lungs.
I'll go do the recovery. Well, we do know that because CF patients tend to be younger, that they tend to do better after lung transplant. And typically we see an acute period where they're in the hospital for about 2 weeks, and then that they go home and they're monitored very closely by the lung transplant center. But what's really important is that you actually talk to a transplant center about what they feel your risk is and what your expectations after the transplant are for you. But we do see some patients who fare very, very well, who can play golf, can do sports, and we have some other patients who may not do as well.
Well, as far as the infection piece goes, you have to remember, whenever you have a lung transplant, the only thing that's different in CF is that you now have new lungs. So you still have bacterial infections in your sinuses, you have bacterial infections that's actually part of the airway that has not been transplanted. You also have lungs that are relatively weakened initially because of immunosuppression. So people are always on medications that makes it more difficult for them to fight off infection. So those lungs can get infected. And so it's very important to work with your transplant center as well as your CF care center to make sure that you're on all the appropriate therapies.
Well, one last question. How would you summarize our discussion? What are the key points that people watching should take home with them?
Well, I think the key points are really come from the title, Navigating the Hills and Valleys of CF Care. And so the reason we chose that title is that when you're on the hill, when you're at the peak of health, you're feeling great. You're able to do all your normal daily activities, you're doing all your daily therapies, and everything is going very well. But then what happens is, well, maybe you start to feel a little sick, you have a little more cough, you maybe lost some weight when you come into the CF center, or you're a little tired. So now you're starting to fall off that hill. You're starting to head towards the valley. That's when we want to hear about it from your CF center, or me as a CF care provider wants to hear about that you're not feeling well. But eventually, sometimes, no matter what you do, you land in that valley, you experience a pulmonary exacerbation, and you get sick. And that's when you really need to come to us so we can treat you, get you feeling better, get you back on that peak of health.
So any other key points, Chris and Betsy?
I think you summed it up really nice. I don't know if you have any, Betsy.
You have any, Betsy?
I think the most important thing is that you should always call your CF center with questions or issues. You should never wait too long.
Wow, thank you very much. I encourage you to look at the CF Foundation website under the treatment section and click on therapies to learn about the different therapies used for CF lung health. Additionally, there's information about lung transplantation and CF nutrition. You can also learn about CF lung health and maintaining it in the Treating with Cystic Fibrosis section, Living with Cystic Fibrosis, the Staying Healthy section. There's information about germs, lung health, information about which nebulizer to use with which drug, as well as information about CF nutrition. This is also the section where you will find the archived patient education webcast, using nutrition to stay healthy with CF, quality CF care and how to raise the bar for CF, updates on CF research, building life skills to manage cystic fibrosis, patient and advocacy issues and answers related to insurance and government programs, as well as how to avoid germs. As with other webcasts, this one will also be archived. I also invite you to join us for our next webcast this fall for an update on the latest in CF clinical research. You can check the CF Foundation website for more information. We encourage you to partner with your CF Care Center and ask how you can maintain healthy lungs with cystic fibrosis. In conclusion, we would appreciate it if you would fill out the evaluation form and tell us what other topics you would like to hear in a virtual CF Education Day. I would like to thank you for watching and submitting your questions, Betsy, Nathan, and Chris for answering the questions, Akron Children's Hospital for hosting, Rick Vasta and the technical crew, Genentech for their unrestricted educational grant, and the Cystic Fibrosis Foundation for making this webcast possible. Thank you.